Perhaps while everybody is coming in, and I can see we've got lots of participants joining us as I speak, I'd like to do some brief introductions and some thanks before I hand over to Sarah, who is our chair for today. So Sarah is an assistant professor at Dalhousie University, and she's the current secretary of NASPEM, and she's going to chair this session. I'd like to start by saying I'm just incredibly grateful and thankful for the speakers and Professor Cooper today who've stepped up to the virtual seminar. It was very disappointing when we had to cancel NASPEM 2020 in the summer because of the pandemic. So it's really a huge pleasure that so many of you have chosen to join us today for the first of our NASPEM UBC seminars. And we will have one each month between now and December. So we really are excited, even though we couldn't welcome you to the beautiful Okanagan. And I'd just like to acknowledge that we do live on the unceded territory and we work at the unceded traditional territory of the Syilx Okanagan people. So before we start with the seminar, I'm just going to run through some housekeeping. Just progress my slide. So just some rules of engagement. So please do keep your microphones on mute and your videos off throughout the session. It does help with the transmission of a large group in a webinar scenario. We are having a Q&A session after the presentation. So please type your questions into the Q&A box, which is on your panel at the top of your screen. And Sarah will be moderating the questions. We're going to record the session and we will post a link to all the attendees off the recording, particularly for those who weren't able to make it today, and that link can be shared. Just before I hand over to Sarah to introduce Professor Cooper, this is a screenshot moment. For our next seminar, I'd just like you to pop in a save the date. We have our next seminar on Thursday, the 19th of November. That will be at 2 p.m. PST, and it's going to be given by Professor David Dunstan from the Baker IDI in Melbourne. And a quick shout out to NASPEM. So NASPEM are hosting the seminar. It was the meeting, the NASPEM 2020 meeting that we should have had in the summer. And for those of you who aren't aware of NASPEM, who've just joined our seminar, NASPEM is a small but multidisciplinary community of researchers, many of us working in various aspects of pediatric exercise medicine. And we're a lively bunch, so if you want to find out more and consider joining, please email Sarah at sarah.moore@dal.ca. So without further ado, I am going to hand over to Sarah to introduce Professor Cooper.
Hi folks, welcome today. The fact that we've had over 140 people register for today just shows that there's so much interest in the topic of COVID-19, schools, and physical activity. And so it's really with my pleasure to introduce Dr. Dan Cooper. Dr. Dan Cooper is a professor of pediatrics in bioengineering and associate vice chancellor for the clinical translational sciences at the University of California, Irvine. He is recognized for his transformational efforts to uncover the molecular mechanisms of exercise that affect children's health, and he is a board certified in pediatrics and pediatric pulmonology, and has conducted NIH-funded research for more than 30 years. So just an incredible career. Lately doing quite a bit of work with COVID-19, and we're all here to see that today. Again, please use the Q&A button. So we'll have Dr. Cooper speak for about 30 minutes, and then that will be followed by a question period. We're excited to go ahead and welcome Dr. Dan Cooper. Over to you.
Great. Thank you, Ali, and thank you, Sarah, and thanks to the directors of NASPEM. It's a great honor to be here. And I'm proud to acknowledge my association with the University of California, Irvine Health, our Institute for Clinical and Translational Sciences, which is our CTSA Award, Clinical Translational Science Award, and the Pediatric Exercise and Genomics Research Center, which is led by Dr. Shlomit Radom-Isaac, who many of you know. So I'm going to jump into this right away. I'd like to get through about 30 minutes and really look forward to question and answers. This is a quote. It's actually from me. It was in the New York Times about 2 months ago. The healthy reopening of schools is the most complex, biologically mysterious, economically profound, and unfortunately, politically charged health issue that I'd ever encountered since graduating from medical school 46 years ago. That's me. It was somehow I graduated back in 1974. I had just come back from working in the mountains near Oaxaca, Mexico, when that picture was taken. And this is probably the most difficult situation I've ever encountered. Why should we care about this? Well, this is a picture from one of our schools that we're working with here in Santa Ana. This is from Superstar Ruben. This was at the very beginning of the pandemic. It appeared on the Instagram of this great school. Hello to all my Madison School friends. I hope you are all doing well. I miss you all. Hope we see each other soon. Stay safe. That school has yet to reopen. So why do we care? And as a member of NASPEM, I'll just tell you a little bit about why I care about the schools. It really is related to exercise and physical activity, because the research that our group has done has always been related to exercise and health, both in healthy kids and kids with chronic diseases. And we've done many, many school-based projects, and many of those projects have been in lower socioeconomic, predominantly minority schools. The pictures on the right are from Project Healthy from about 15 years ago that was published in the New England Journal of Medicine. We were trying to deal at that time with a different pandemic, and that was the obesity pandemic, which has not gone away. Then we had the luxury of establishing a lab, as you can see, right in the school gym. And presciently, one of our lab workers was worried enough that she wore face masks and face covering even in those days. And this is one of our ICTS, our clinical translational research nurses, at the site of the school where we actually drew blood. So these experiences of working with these schools and these kids really, really got me worried. And I knew that we had to sound the alarm. So back in April, we organized a group, as you can see here, of remarkable scholars, both in pediatrics and in education. And we got a commentary published in the Journal of Pediatrics that, if you care to read, you can see the PMID here. The Reopening Schools, the Case for Collaboration, Constructive, Disruptive of Pre-Coronavirus 2019 Expectations and Creative Solutions. And little did we realize at that time how political this issue was going to become, and to this very day, how political it is and important it is. And one of the things that we wrote that's particularly relevant, I think, to NASPEM and to this audience is from the paper. Even as we curtail physical contact, we must not reflexively abandon after-school activities and physical education. We wrote in the article, early life physical activity is beneficial for child health and health across the lifespan, and physical fitness in children is associated with improved school learning. And conversely, the lack of participation of adolescents in PE classes is associated with social isolation and loneliness. We'll talk more about this in a second. And we ended by saying preparations for school reopenings should include novel approaches to PE, structured recess, and access to safe after-school activities. And I think in general, we have failed, at least in the United States, to have done this in an effective and an organized way. I wanted to put the sort of the biology, the politics, and the social aspects into a construct that perhaps is a little bit easier to understand. So this is physical activity, maturation, immunity, and these are the poorly understood mechanisms that we still have to address as we look at the evolution of the COVID-19 pandemic, particularly as it relates to children. So we have physical activity, we have the immunobiology of exercise, and overlaid on this, of course, are all the changes that occur with growth and development. And we know with regards to physical activity that it's not just play, but it's an essential component of healthy growth and development, and it's beyond the muscles and the bones. We know increasingly that it affects the development of the brain, behavior, cognitive learning, etc. We also know that exercise stimulates a myriad of innate and adaptive immune responsive, some of which I think might well be related to how one responds to a viral infection or to a vaccine. And finally, we have to recognize that humans are very unique mammals. We're actually the only mammal known, including primates, that have a pubertal growth spurt. And the duration of puberty is so long that when you think of environmental influences like exercise on biological processes like epigenetic signals, we have an unusually long time in which the environment can actually affect epigenetics, and other mechanisms, and affect health across the lifespan. So these three areas, I think, are something we should all be thinking about as we look at the broader evolution of this pandemic. Why else should we care? Well, first, there is mounting evidence that school closures adversely affected health and the learning of children and adolescents. You know, schools were closed summarily throughout the world as soon as the pandemic began in February. And there's some key questions, and that is, will children or adolescents become infected and sick as they reaggregate in schools? What then is the risk for school personnel? Can K-12 students spark outbreaks not only at school, but throughout the neighboring communities? And of critical importance is how do factors such as socioeconomics, race, ethnicity, and special needs of students affect COVID-19 as schools reopen? As noted, schools closed at the start of the pandemic, and the data to support this was pretty scant. For those of you who are history buffs, read about what happened in 1968 at the time of the Hong Kong flu epidemic, when in France, for example, there were so many people that were dying that they had to convert subway stations into morgues. But we didn't have this social media and the reporting that exists today, and the idea of shutting down society was not something that people considered. I'd also like to point that organizations like the American Academy of Pediatrics, the National Academy of Medicine, and DMC, that's me, really are in favor of trying to restart schools if we possibly can. And early data, the data from May, based on an analysis in Europe and Asia, did not in general show severe school-stimulated COVID outbreaks, but there have been outbreaks. And it's really, really important to remember for the people who take the position, oh, just send the kids back to school, that even in Europe, in May, when it was voluntary to go back to school, that the schools did not return to status quo. They didn't just open the doors and let the kids come in. Most countries implemented physical distancing, stringent hand washing, and face covering, and about 40%, at least in Europe, of the parents refused to send their children back to school. Now things have changed. Since September, most of the European schools have reopened, and they are now obligated to have kids back in school, and it remains to be seen what the results will be. So it's really, really important to remember that, yes, in the pandemic, children are not miniature adults. And here's a really nice review that appeared in July in the American Journal of Physiology, Lung, Cell, and Molecular Physiology, that addressed the question, understanding the age divide in COVID-19, why are children overwhelmingly spared? And we know that the symptoms in children tend to be much, much less severe than in adults. And as a friend of mine who's is an infectious disease expert told me, if we're really going to understand this pandemic, we need to understand why the disease seems to manifest differently in children than in adults. So this just from that article looks at disease severity in school-age children, appears to be less than adults. So this is the trajectory of a worst case in an adult. And of course, in the past several months, we've all been seeing these terrible stories of people getting a little bit of disease, progressively becoming severely ill, ending up in an ICU, and sometimes dying. We didn't see this in most adults. We tended to see this mostly in older adults. And the course in children was like this. We have to recognize that there is multi-system inflammatory syndrome in children. You've got colleagues at the University of Toronto that have really led the way in trying to understand exactly what this is. We don't completely understand it. This is a disease that results in hospitalization, but fortunately, very, very few, very low mortality, even in kids who end up in the hospital. And there are various ways of trying to treat this right now. So this is a nice figure from that article that tries to look at the maturational difference between the pediatric and the adult lung that might explain a little bit of the difference. I think one of the interesting things is the ACE2, the angiotensin converting enzyme receptor. The virus, the SARS-CoV-2 virus, likes that receptor, and there is evidence to suggest that the density of that receptor in the lung is lower in children, And so that's one of the potential mechanisms to explain why the disease might be less severe in children. The other is the phenomenon of antibody-dependent disease exacerbation. We see that in dengue fever, for example, where you tend to have much more severe dengue fever in adults who had been infected with cousins of the dengue fever virus and had elicited an antibody response to the cousins, but rather than provide protection to the dengue fever virus, those additional antibodies actually exacerbated the disease. So this phenomenon of antibody-induced exacerbation is well known. We don't know if that's what's taking place with SARS-CoV, but since there are many coronaviruses out there, there is a theory that the earlier exposure to common cold may make it worse for you. So these are some of the reasons that we might see differences in disease expression in children and adults. As I mentioned, there's decreased expression of proteins like the ACE2 receptor. There may be immune system differences that include a relative preponderance of the CD4 T cells and decreased neutrophil infiltration. It's the activated neutrophil, which doesn't go away, which even after the virus load goes down, continues to cause lung damage, not only in SARS-CoV-2, but in many adult respiratory distress syndrome type of situations. There may be a decreased production of pro-inflammatory cytokines in kids. There may be an increased production of immunomodulatory cytokines in children compared to adults. And the developing lung in children may have a greater capacity to recover and repair after viral infection. And, you know, I think many in the audience realize that these are topics that we, folks who are interested in exercise in children, are also very, very interested in. And understanding the relative contributions of these above processes to the protective phenotype in the developing lung can guide the trial of appropriate therapies. And just to show how relevant it is, this is work from Shlomit Radom-Isaac in PERC. And this just looks at the effect of brief exercise on gene expression in peripheral blood mononuclear cells, comparing early and late pubertal kids. Just a couple things that come to mind. First of all, although there is overlap in the genes that are affected, early pubertal genes and late pubertal genes are not exactly the same. And when you look at the genes in common that are affected by a brief bout of exercise, almost all of them are related to immune function, antigen processing and presentation, natural killer cell, B cell receptor, and so forth and so on. So there's a real fertile area of research that we still need to address. And we also know that exercise causes inflammation, or the increase of inflammation. A study we did many years ago with Dan Nemeth, inflammatory response to exercise in high school wrestlers. This is the percent increase after a mock wrestling practice. If you look at things like IL-1 beta or IL-6, even in the urine, you see big increases. TNF-alpha, IL-1 receptor antagonist. These all suggest that exercise stimulates the immune system. How this works in the SARS-CoV-2 virus, we don't know. But we are beginning to understand, and this is very recent data from Mexico, in a study that looked at comorbidities that actually predicted acute respiratory syndrome and coronavirus 2 test positivity in Mexican children. And they concluded that the findings from their study indicated that obesity, which we know is associated with physical inactivity and is also associated with a mild hyperinflammatory state, is not only associated with severe COVID-19, but may also predispose to this disease. So what has the impact of school closures on K-12 kids been? And it's not been a happy story. There is interrupted learning, there's poor nutrition, parents unprepared for distance and homeschooling, particularly when there are issues of socioeconomics and access to high bandwidth internet. There's gaps in childcare. We're seeing in our region, in lower socioeconomic neighborhoods, for example, all kinds of unsupervised daycare opening up because the parents have to work. And in upper middle class neighborhoods, what's happening with the school closures is that groups of parents are hiring teachers away from the schools, and they're meeting with these pods, which sit and do distance learning together. And again, we don't know what's going on. High economic costs, unintended strain on the healthcare system. This includes the poor vaccination that we may be seeing in kids because they're afraid to go to their doctors. There's a rise in dropout rates. There's all kinds of kids that are simply unaccounted for, increased exposure to violence and exploitation, and social isolation. So this is the unfortunate legacy of not having schools open. And when it comes to physical activity, the data are now starting to emerge. I've got 3 examples that I want to go through. This is a paper, again, all very recent, from Frontiers in Pediatrics. This is health-related behaviors among school-aged children and adolescents during the Spanish COVID-19 confinement. And these authors found that their study suggested that COVID-19 confinement reduced physical activity levels, that the closure of schools during both strict and relaxed confinement could play a key role. So even if you left the kids out, keeping the schools closed seemed to have an effect. They also reached the conclusion that it was unlikely that physical activity behaviors could be compensated for by just doing stuff at home. And part of this, of course, is we know, and everybody in the audience understands, that physical activity is such a social activity. And we think about the impact of physical activity and exercise, particularly on cognitive development and learning. I think it's that social side of physical activity and the direct stimulation of the brain, and the fact that, and we see this now in studies from rodent models even, that probably exercise itself activates many of the executive function, cognitive brain areas, because when you exercise, you've got to do spatial recognition. You have to do a recognition of time and what's around you. And so exercise probably stimulates right in the brain many of the cognitive functions that are so important. And in human beings, it's a very social activity. And one of the things that I found really interesting in their study was that adolescents with lower physical fitness were observed to greatly reduce their physical activity more than others. So again, you have a vulnerable population of kids who may be already physically inactive, already obese, and the impact of the school closures was even worse on those kids. Here's a study from the United States. Genevieve Dutton was actually one of our faculty members a number of years ago. A study that came out in BMC Public Health. And what she looked at was, and this again was survey data, and what we show here is the percentage of children in this case where they noted that their change in physical activity as a result of the shutdown. And I think what you want to look at is, first of all, these are the older kids, the hash bars, but you can see somewhat less, much less, particularly in the older kids, but in all groups. So there was the survey revealed what we would have intuitively felt, but certainly here's some data to indicate that that's exactly what's going on. That is, that the imposition of the shutdowns had a pretty significant effect in reducing physical activity. And this is the converse. This is much more of sedentary behavior. And here you even see it more clearly, again, about equal in the 2 age groups, but much more sedentary or somewhat more sedentary behavior as a result of the pandemic. So the data are starting to emerge. They suggested that, as we noted, that US children performed less PA and did more sedentary behavior. Although school and park closures and cancellations of team sports and organized activity classes had a profound effect on children's physical activity and sedentary behavior, especially among the older children. And in order to avoid permanent changes in behavior extending beyond the duration of the COVID-19 closures, measures must be taken. And I think this is something we should pay attention to promote home and neighborhood-based physical activity during children's leisure time activity. And of course, from Canada, this is, I think, a great title, Don't Walk So Close to Me, Physical Distancing, and this was an adult physical activity in Canada. They found that MVPA, leisure physical activity, and steps significantly declined, as you would expect, immediately following the declaration of the pandemic in Canada, and attenuating the loss of incidental physical activity should be a public health priority in response to future pandemics or a second wave of COVID-19, as it may have significant long-term implications for the physical and mental health of Canadians. So what's going to happen when schools reopen? Here's I think a wonderful photo from Zimbabwe last month as their schools reopened. I want to point out that in the United States, we have just seen a real chaotic situation around the schools. As I mentioned, I had advocated for months that as a nation, that we get together and figure out how we can open the schools safely. The public schools are particularly challenged because they have to do with governmental agencies and teachers unions. And while there have been great attempts to say from the 30,000 foot level what you need to do to open the schools, as everybody in this audience understands, every school is different. And the issue here is not so much the science, but the logistics. And the question that every parent wants to know is, when I take my kid to school at 8 o'clock in the morning on Tuesday, is that school a healthy place? And it's not even about issues of risk, because most parents understand that there will be some risk, but whether they feel confident enough that the school is prepared. Now, what happened in the United States is that private schools, in many cases, were able to operate on their own. And in our state, in California, where there was a mechanism to have waivers when earlier in the summer schools could not reopen by state law, the private schools dominated the approval process for reopening. And let me show you the example of the confusion. And nothing has changed from the beginning of this pandemic. So this is from a newspaper in Israel, which has had a tough time with the pandemic, from 3 days ago, October 21st, 2020. This was the front page of their newspaper. Kids more likely to catch COVID-19 than adults, Health Ministry finds, and they write, the return of children to schools may accelerate the spread of the virus, both throughout different age groups and throughout different geographical areas. The very next day, in the same paper, experts pen fundamentally flawed ministry report that kids are super spreaders, and they point out that the data in the report clearly demonstrates that children are less contagious and they most often get infected from adults, not the other way around. I would say that this is probably the case, and that we should probably try to open as many schools as we possibly can. We've tried, and I think other members throughout the country have tried, from academic health centers, to work with the schools. In our group, we've gone out to schools, we've helped them develop their own plans. It's greatly appreciated through individual schools when you do this. We even published an algorithm, which if anybody wants to take a look at, was in the Journal of Pediatrics, for what you do with the child who develops symptoms in school. We had some of our artist friends put this together. This was approved by Orange County Healthcare Agency and is being used in many, many places. And our school nurses and our school personnel find this very, very useful. And we're working on one for the teachers who may become symptomatic as well. We also are doing research, and this represents a partnership between UC Irvine, the Children's Hospital of Orange County, and the healthcare agency. We have a study ongoing where we're actually going to make measurements of SARS-CoV-2 and serology in kids. We have two major aims: to measure SARS-CoV-2 transmission in students and personnel in selected schools as they open. We've got about 60% of the kids are also agreeing to a blood draw. We're doing an anterior nasal swab, and we're looking at SARS-CoV-2 and 20 co-circulating respiratory viruses. And we're doing this at the beginning, and then in December, when 4 or 5 months have passed by, and we're going to, in cases where we find positive viruses, we're going to sequence them to look for the molecular phylogeny, that is, to see if we can get an idea of where the virus came from. And the aim, too, I think, is going to be very interesting to this group, because a lot of people say, you know, do physical distancing and do face mask wearing, but how do you measure that? How do you know that it's actually happening? So our second aim was to measure the fidelity of the mitigation protocol. And so what we did was we took the SO play, which I think many of you are familiar with, which has been around for 15 years. It's a systematic observation of physical and leisure activity in youth. And we've adapted it to include measures that are relevant to the pandemic, like face mask wearing and physical distancing. We've been working with Ricky Camplain and Gigi Lopez from the University of Northern Arizona, and our own Shlomit Radom-Isaac, whom everybody knows. And they've actually been out in the school, and they're about to publish a paper about how we might use this as a way of putting numbers around the mitigation. We've got 4 schools. 2 of them are in high hit areas, lower socioeconomic, high surge areas. One is a charter school that cares for children with special needs, such as autism and Down syndrome. You can imagine that when you talk about things like physical distancing in that population, it's very challenging. And a private school that serves predominantly middle and upper middle class families. This school has been open already for a month and a half. They invested $1 million and were able to in reopening the school. And there's a couple of issues before I end that I want to bring up that are really important. Vaccines, physical activity in children. Here's a couple of papers, one from our group, that physical activity can influence immune response to vaccination. And in this one, we showed that there was reduced specific antibody response to tetanus booster shots in obese children. So as the vaccine develops, we have a role in trying to outline what the role of physical activity may be in the success of the vaccine. And then finally, there's an ethical question, and that is, when you consider testing or giving a vaccine to children, we have to remember that the disease is much less severe in children. It's not like polio. It's not like diphtheria. So weighing the risks and the benefits is a very different equation than it had been in the past equations regarding diseases, again, like polio and diphtheria. And I want to end with the following. This is not the time for NASPEM to stay quiet. And Sarah and Ali and everybody, I think you guys are fantastic for having these monthly meetings. This is the time for us to try to do a lot of stuff, to build a global coalition of pediatric exercise and physical activity laboratories, to create common normal values and interoperability in kids. This is one example. If you get the slides, look it up, you'll see what we're talking about. To inaugurate a virtual community to share cardiopulmonary exercise testing in children and adolescents so that we can learn from each other. To restructure remuneration, at least in the States, for pediatric exercise laboratories and develop standards for all personnel. And to get NASPEM more involved in the larger organizations like the National Academy of Medicine, ACSM. And we play such an important role now as we see these threats to physical activity as a result. And of course, to build a robust research funding mechanism. And something that I was supposed to talk about in August that I don't think we should forget about is the United Nations Convention on the Rights of the Children. I think we should work together to add to that convention the right of every child to be physically fit, and to point out that during the pandemic, the children that seemed to do worse were the ones that were not physically fit and were obese. I'll end with a quote from our friend Albert. As for the search for truth, I know from my own painful searching with its many blind alleys how hard it is to take a reliable step, be it ever so small, towards the understanding of that which is truly significant. So thanks. Fiat Lux is the Let There Be Light from the University of California, and I just would love to hear questions and responses from the audience.
Great. Thank you so much, Dr. Cooper. Lovely to see some of the work that you've been doing in this area, and it's quite far-reaching, so really appreciate your talk today. We have opened up the Q&A, so if you would like to ask a question, there's a Q&A button. It could be at the bottom of your screen or the top of your screen, depending on how you're using Zoom today. And so it's there for you to ask a question, or you can send a private message in the chat function, and I'll be using both of those in order to field questions today. But I'll just start out. So you showed some pretty significant data that discussed the reduction in physical activity during the COVID-19 period, and we're starting to see those data come out in the US and Canada and across the globe. And I'm just curious to know if we're worried about kids meeting the 24-hour behavior movement guidelines, what do you think are the short-term impacts of kids being inactive, and what are the longer-term impacts, and what should we do about that? So maybe we can start there.
Let's start with the second part, the what can we do about that? So we have tried in our region to spread the word about physical activity that can be done safely in schools. So there are really creative people in Canada and the United States. There are many places out on the web that describe fun games that kids can play that are that'll get you into MVPA, but at the same time will not necessarily result in more physical contact above and beyond what we would think would be safe. So we have not done a good job. I can tell you that in the private schools, a lot of them have paid attention to that because physical activity is very important in the private schools and in some of the charter schools. The public schools, at least in our country, are so, as I said, it's just hard to describe. They are so in such a state of PTSD and anxiety about this because of teachers' unions and parents and the whole testing question that, as you can imagine, the idea of paying attention to safe recess or safe physical activity when they're trying to figure out how to do distance learning, you know, in lower socioeconomic neighborhoods where you don't even know if the kids have high bandwidth computers, unfortunately, it's fallen by the wayside. In the state of California, for example, even the mandated hours of physical activity are now no longer mandated, but they're sort of advised, is the latest governor's thing. So you know what's going to happen in those situations. And then with hybrid learning, where the kids may be only a number of hours per week at the school, it's going to be left up to the kids. Now, are some of the online physical activity programs that people are implementing successful? Remains to be seen. It remains to be seen. Could we be using our parks a little bit? Yeah, better. Yes, we could. Should we have organized, you know, activities? So the people that have studied, for example, physical activity use in parks, I think the most salient lesson that I got, it's not the physical facility, it's whether you have personnel to work with the kids, because that's what convinces parents that it's safe to do it. And again, we haven't yet done organized approaches to this.
Yeah, yeah, and some of our research certainly shows that connection between parent and child activity levels in the family as well. So yeah, thanks for that, that comment. We have a few more quick questions that have come in, so I'll go ahead. Ted Kaplan is asking, can you comment on the data so far related to weight gain in children since COVID? Do we have any data that's showing changes in body composition at this point?
Scant, but it's coming in the way you would think it is, and that is that kids seem to be gaining weight. I haven't seen, and maybe some folks in the audience have, I've been looking for it, but you know, actual studies of body composition have yet to be done. Now, one of the problems, of course, is that our typical research centers have been closed mostly. So it has been hard to justify if you wanted to do DEXA scans or bring a child in for a research center. At our own institution, we're still struggling with 2 major exercise studies in kids that focus on healthy volunteers, and we just recently have gotten the okay to start. It does remind me that if there are people out there who are interested in generation of aerosols, this is a topic that we as pediatric exercise scientists should be thinking about, is what is the pattern? Is there a maturational pattern of aerosol generation? And the related question is, what's the impact of wearing a face mask in a child on exercise responses?
Thank you. There's a similar or somewhat related question from Megan James. She's going to be starting to do some research, and of course, as you just discussed, we're just starting to be allowed many of our research units to get back into doing research. So she's looking at doing physical activity interventions, and do you have any other suggestions for what types of interventions you could be doing during the pandemic related to physical activity? And she, I believe, is looking at in the early years and elementary school years. So if you could speak to that.
Again, and maybe we can post these later. There's, I think what we need to study is how well the ideas about physically distanced, but socially interactive physical activity is working. You know, we've had a lot of creative teachers and physical activity folks come up with ideas. I think what we need now to do is to study how effective they are. I think we should use some of these tools like the adaptation of so play, which is direct observational, see if they're actually working. And then I think we need to talk to the kids about whether these activities are fun, because you know, the fun is not a trivial word. Fun is the assessment of the child as to the biological efficacy of that activity. Mm-hmm. And you know, if the child says it's not fun, that means that biologically we're not achieving what we need to achieve, because that kid's brain wants to integrate that activity into something that they want to repeat. So those are the kinds of questions I would be asking about the new way of approaching physical activity. You know, how long is this going to be around? I don't know. You know, we just don't know. We have a vaccine that's coming out. Let's hope that it works. Are we going to have to be revaccinated every year? And then, you know, start to think about, will there be other pandemics in the future, et cetera, et cetera.
Yeah, thank you. Yeah, and there are such differences in terms of what after-school programs are open, what sports programs have restarted, and what that looks like for return to play. I know that I've been part of those conversations across Canada with return to play and return to sport. A question about...
Sarah, I just wanted to add,
yeah.
I think everybody here understands that physical activity is really important to kids. Mm-hmm. It's a biological function. And if the kids are staying at home and can't participate, then we are, you know, really missing the boat.
Yeah, thank you. Yeah, I know for my boys, they've been doing kickboxing, but now they're in their circles, and so it's not as fun. So I know that you spoke to that. It still needs to be fun for them to want to continue to engage and participate. In Canada here, and I don't know what's happening with your, you know, if this so-called second wave, whatever we would like to term that as, but we're certainly seeing an increase in the number of COVID cases here in Canada that differs across from province to province and within the territories. Any suggestions of how the schools should be responding to this this increase in the number of COVID-19 cases, and if there should be changes in some of these guidelines you had mentioned related to using the school ground or using the gyms? The question here is just in terms of what should we be doing and what should the schools be doing related to this second wave?
Yeah, so the big threat for the schools is going to be so what happened in California and most of the United States is that the decision to open schools was based on the environment, the infectivity rate, et cetera, in the neighborhood. And until the waiver period in the state of California allowed certain schools to open, nobody really paid attention to the quality of the particular plan at a given school. So one thing is, I think, is that individual schools need to really develop plans, and the Board of Education and the health departments need to help individual schools develop those plans. There are going to be outbreaks. The virus is here and it's highly infectious. So there will be outbreaks. So the question is, if you have a given class, if you've cohorted your students, right? So you know that teacher A is with a group of students B, and if the outbreak is limited, then you can with confidence not have to close the whole school down, even if there's a second wave coming on. You see what I mean? At what point do you just say you have to close the schools if the infectivity rate gets so high? That's a really tough discussion. Everybody thinks that the scientists, quote, no, they don't. And they're guessing just like everybody else. I think in the meantime, we have to get at this fundamental question of how much are children super spreaders? In other words, how, you know, are kids spreading it just among themselves, not getting very sick, but then not spreading it to other people? There's a socioeconomic side of that question as well, because if a child from a lower socioeconomic school goes home to an apartment, which is 700 square feet, we use feet in the United States, 700 square feet, and you have multi-generations living under the same roof. A grandma, a grandpa, uncle, aunt may have heart disease or obesity. That's very different than a kid in an area in my neighborhood, Newport Beach, for example, which is an upper middle class neighborhood, goes to a 3,000 square foot home with two relatively young, healthy parents and one sibling. Those are two very, very different environments, and will weigh upon whether you close the school or not. So I think, Sarah, the long-winded answer is schools should try to stay as open as long as they can by doing as much of this mitigation and following the effectivity, the fidelity of the mitigation as much as possible. That's why I like the use of this adapted SO play, because we can get some numbers and we can determine, gee, in your school, you had an outbreak, but we also discovered that nobody was really wearing their face mask correctly. So at least you might be able to do something about that.
Yeah, thank you. Yeah, and I think that this evidence is just so important for us to keep pushing to our public health officials and those making decisions related to education. And another question's come in from someone who wanted to be anonymous. What would you say to public school across North America who want to ban school sports, citing that it's for the safety of the children?
There are ways of doing school sports, and we've got some of my friends from Duke University have been addressing this issue about how to bring back some of the school sports safely. I think what happened early in the summer, at least in Orange County, I think throughout the country as well, is that some of the sports opened up again, but there was no mitigation. There was no symptom checking. There was no thermometer checking. They weren't wearing, sometimes you can't wear your face mask, but when you're sitting together on the bench, you should be wearing your face mask. So I think some of the outbreaks that we saw in sports were a result of not really thinking through how to reopen the sport. I'm in favor of reopening the sport as much as possible. And I'll tell you why, because I'm not sure that closing the schools down prevents the spread of disease, or closing the sport down prevents the spread of disease. Now, so, you know, we've got in Orange County, California, and in LA, we have 1.2 million K through 12 students. So people say, well, close the schools will prevent the spread. I'm not sure that assumption is correct. In the United States, we've seen the largest increase in pediatric COVID in the summer when the schools were closed. And the idea, well, certainly among adolescents, that they are not going to interact with each other just because you close the schools, that's obviously not true. And even the younger kids, as I said, in lower socioeconomic neighborhoods, both parents have to work. We're seeing these kids go to unsupervised daycare. I don't know if the people running those daycares understand physical distancing or hand washing. So the problem is the cure worse than the disease? And I think that preventing kids from being involved in sports, it's now 8 months or 6 months, right? Are we going to do this for a year? Are we going to take a year out of the key developmental time of a child, you know, and so you can't be in sports when in fact we have no guarantee that that's going to prevent that kid from getting the disease? And what we should focus on is making sure that if the child goes to sports or if the child goes to school, that those places are as healthy as they can possibly be. I would rather an adolescent goes to school and learns about physical distancing and learns about what it means to wear a face mask and learns what it is to wash your hands on a regular basis than he or she get that information from his buddies in the street. Now, we cannot eliminate the danger. The virus is here. And until we're vaccinated and have herd immunity, it's going to be here, and we have to face it.
Thank you. There's been some great comments in the chat. So Karen Pfeiffer just posted that the ACSM published a call to action addressing COVID-19 and return to sport and physical activity, but some really great comments. So if you're not looking, take a look at the chat. But I'll just go in, I have one more question about physical activity, and then there's a couple of other questions we'll go into transmission and other long-term consequences. So this came up a little bit here, but just can you speak a little bit about the concerns around children's mental health and all of this? So we've talked about kids being inactive. What are the data, what do we know about children's mental health in the state of the pandemic?
So there are data for both college-age kids and high school kids about increasing depression, increasing social isolation, some data about suicides. I mean, suicide is hard because thank God it's a rare event, and so it's hard to know exactly what's going on, but the data from those populations strongly suggest that the social isolation imposed on children is not good for mental health. And that what I can tell you we work with the Children's Hospital, and in my discussion with our psychologist friends there, they're seeing a huge number of kids that want consultation. Just again, it's not hard data, but just the number of parents that are calling and the number of kids that are calling for help. Part of it is, of course, fear and anxiety. I mean, if you listen to the news, I mean, we should all not listen to news anymore because it's pretty terrible. But I think, in my discussions, this is anecdotal, in my discussions with kids, there's a lot of anxiety, even among younger children about virus and transmission. And am I going to die? And if I'm not going to die, am I going to give this disease to my grandma or grandpa? So we tend to ignore mental health in general. And obviously now we can't afford to ignore it. And I think it's tied to physical health and physical activity. It's one of the themes that the members of NASPEM should continue with and have begun to before, of course, but physical activity and physical fitness is tied very much to mental health. It's tied to sleep. and healthy sleep. These things are all together. We don't like to think of them that way because as scientists, we kind of like to focus on a narrow thing, but they're really quite related. And what I think the pandemic has done is it shakes up everything, right? It shows the parts of our public health system that are not working really well, and it shows the impact of disparities and health inequities in our system, more than we've seen at other times. And I think mental health is one of the areas where, at least in the States, we don't have adequate facilities for kids right now.
Yeah, thank you. I know that in some of our work, we've seen that family distress levels were pretty closely related to the physical activity of the child during COVID-19. So certainly an area that we can continue to look at.
One of the interesting things, one of our groups has what's called a Conti Center that studies actual brain development in response to environment. And their theory is that chaotic behavior in a family actually affects how the brain is developed, and it can lean in children to anhedonic, you can't get pleasure from anything. So what they've discovered is that routines are very, very important for kids. Routines, when you eat, when you exercise. So to your point, Sarah, I think it's a very good one.
Well, routine has certainly gone out the window for the last few months, but let's move on to some other questions. We only have about 7 more minutes with you here today, Dan. So a couple of questions regarding the long-term implications of the virus about damage to the heart and lung tissue, and Brian Abel echoed that question as well. So any thoughts on return to school, as there's a little bit of an unknown risk around heart-specific conditions during and after the recovery from a COVID infection?
Right. So, the data for adults are just coming in because the pandemic, has only been around for 6 months or 7 months. So, adults who were severely ill, not unexpectedly, you are seeing longer term damage to the lung, the development of pulmonary hypertension, pulmonary fibrosis, some reduction in cardiac function as well. Are we seeing this in kids? So it remains to be seen. Obviously, the kid who's had the mild or asymptomatic, virus will have to follow over time and see what happens. I think exercise testing will be a really good way of determining whether there is a subtle effect. I mean, we know this when we study diseases like bronchopulmonary dysplasia or lung disease of infancy, where sometimes you can only see an effect when you exercise a child, right? So I think that's going to be useful. The kids that have had the multi-inflammatory syndrome are going to be a group that we're going to have to follow. I don't think there's enough of a cohort or that enough time has elapsed yet. But, there is some relationship with Kawasaki disease. We don't really know what Kawasaki disease is either, but Kawasaki, which has a high prevalence for coronary artery pathology, we know those kids have long-term consequences. And you can sometimes see that in exercise testing. You can certainly see that in electrophysiological testing. So I would think that what we should do first is make sure that we have a registry of the kids that have had the multi-inflammatory syndrome and get them to sign a consent form so that we can contact them and so that we can study them along the line. And then I think we should study the kids where we know they've had a positive COVID test, even if they were asymptomatic. How will they respond next year? How will they respond to other colds that they get throughout the years? Will they have a proclivity to develop asthma, for example, because you've revved up the immune system in ways that were unexpected? These are great questions.
Yeah, thank you. Yeah, certainly this will lead into lots of areas where some of the NASPEM folks can dive into in the future. A question from a couple of folks around, we're entering into cold and flu season. And so what should we do in terms of the school and community environments related to that? I'll ask that generally, but specific to kids returning to school with cold symptoms as well. Any thoughts?
I'm happy to share the algorithm, which is a very specific thing that we spent a lot of hours thinking about, and it's kind of a nice algorithm. So the problem, of course, is that the early symptoms of COVID and the early symptoms of every cold and flu are quite similar. So what do you do? So answer A, of course, is the flu shot, right? Our schools in California, by law, cannot require flu shots. I don't know if this is true in Canada. At my university, they declare that we cannot return to work without a flu shot. Within 2 days, they had 5 lawsuits, the University of California, just so you know. But I've had my flu shot. So we have to encourage, for the pediatricians out there, you need to make sure that your kids get the flu shots, that the parents get the flu shots, for obvious reasons. One, we'd like to, if we do have a second surge, we want to keep as many people out of the hospital as we possibly can, because if we have a second surge from COVID and we have a bunch of immunized people who get bad flu and need to be in the hospital, we're not going to have enough ventilators. So we have to encourage flu shots. It's interesting, some of the early data from some countries suggest that the physical distancing has reduced the spread of influenza, as you would expect it to. And I've got some nice papers from 2015 for people who don't believe in face masks that show from 2015 that face masks and hand washing reduced influenza spread, which spreads in many ways similarly to COVID-19. So I think the main thing is flu shot. The second thing is to make sure that the schools have a really clear way of dealing with a child who becomes symptomatic. That's a discussion between your local public health, et cetera, how you quarantine, so forth and so on.
Yeah. We have so many questions that we could spend this afternoon. I'll ask one more, and I'm sorry if I haven't gotten to the questions of everyone in the audience. Feel free to email those to me and I'll pass those along to Dr. Cooper. But just related to what you were just talking about, any specific recommendations for exercising and related to aerosol generating activity in kids?
I don't know, and maybe I'm just ignorant. I mean, I've read the aerosol literature. That's a very controversial field. When you talk to the aerosol physicists, they get into big discussions like about the value of the anaerobic threshold, right? What's an aerosol? Is the virus there? This is a ripe area for study, everybody, and we need to work with our engineers and, figure out what the pattern of aerosolization is. Ventilation, I mean, my God, you talk to 3 people who are experts on ventilation and they give you 3 different answers about how you should properly ventilate. We don't know. This is an area where an organization like NASPEM, we need to take the lead and get at these answers.
Yeah. Yeah, thank you. I just wanted to remind everyone, and again, apologize if I didn't get to everyone's question. There's a way to save the chat. So if you click the 3 dots on your chat function, you can save the chat. There's been some great links that have been posted there. Again, I wasn't able to get to everyone's questions, so you're welcome to email me at sarah.moore@dal.ca if you're interested in asking Dr. Cooper another question. That's sarah.moore@dal.ca. And again, I'll just thank you, Dr. Cooper, for taking the time with us today. We're so excited to learn from you and with you, and on behalf of NASPEM, we're just really grateful that you were here today.
Thank you, and thanks everybody for your great questions.
Great. Just a reminder, so if you'd like to attend our next session, it is on Thursday, November the 19th at 2 p.m. Pacific time, hosted from NASPEM and UBC Okanagan from Dr. Ali McManus. Thank you so much, Dr. McManus, for putting this together today. That will be with David Dunstein and looking at sedentary behaviors in public health. So we're 1 minute over, so we'll go ahead and sign off for today. Feel free again just to use the chat or to contact me, and you can save the chat there by clicking those 3 buttons. Thanks very much, Dan. Thanks everyone for joining us today, and on behalf of NASPEM, hope you have a great day and a good weekend. Thank you.
Thanks, Sarah. That was awesome. Fabulously chaired. I really appreciate it.
Oh, good.
Yeah, that was, he's a good speaker, and it was just enjoyable. So thank you so much for
of course.
Great discussion as well. Beautifully led.
Oh, good.
So I'll be in touch with the next one. We're just finalizing the advert, and it'll
Perfect.
be soon. Thank
Wonderful.
you, Sarah. Have a nice day.
Thanks, you too, Ali. Take care. Thanks again.